Hello everyone. This video is about case of laparoscopic appendectomy for appendix in a retrocecal position where the appendix lies in a subhepatic region. This case is not a straightforward case like our previous surgery. So, like in any laparoscopic surgery, we just have to do a thorough diagnostic laparoscopy. And once the diagnostic laparoscopy is done, the second step will be your port positions. So, the first port in lap appendectomy, which I usually follow, is a left lumbar port. And over here I'm using a suction cannula to understand the anatomy of the appendix. Like I said, the hallmark of any laparoscopic surgery is understanding the anatomy first. So now that I know the appendix is in the subhepatic region, my second working port will be in the suprapubic region. This is something I usually follow when the appendix is in retrocecal subhepatic region. So these are my preferred working ports in case of retrocecal appendix. Now you see I'm taking down the momental adhesions. Over here we still couldn't see where the appendix is. What I'm doing right now is teasing off the tissue so you can fairly see so that is the tip of the appendix. So it's always a better practice to double confirm it by running it from the base to the tip. And so once you've understood the anatomy, it's a retrocecal subhepatic appendix buried within the hepaticocholic ligament. So now we'll be starting the dissection. The best practice here is to put a gauze in the abdomen and use the gauze as a dissector. Over here I'm opening up the hepaticocholic ligament to make the tip of the appendix visible. And so the trick over here is to take the tissues in small increments because the hepaticocholic ligament is fairly an avascular space, but there are the small cholic vessels which will run from the transverse colon and the liver. If they snaps through your dissection, it will obscure the field of vision. So be in small increments. Make use of a good vessel sealing device. So the tip in such cases is to have a really good patience, and you should always respect those anatomical planes. And you see, you're using a vessel sealing device. You see, like I'm not resting the device on the tissue. So whenever you use it, you should always hold, lift, and then seal it so that there won't be any transmission of the energy. And the use of tooth grasper to hold the appendix is always a controversial topic. And the reason we use a tooth grasper is one, it will give you a good hold of the tissue. And please make sure you're holding a tubular structure with your traumatic grasper, not your colon. So now that we opened up the hepatocolic, now I'm just dissecting those omental adhesions from the appendix to the transverse colon. So you see, these are those anatomical planes I was talking about a little earlier. So once you respect the anatomy, it will always open up. Now you see, it has clearly opened up between the tip and your omentum. So slowly we are able to see that there's a tubular structure coming into our vision. And the second thing is, in such retrocecal appendixes, so you barely find any mesoappendix there. Now what I'm releasing is a part of those omental adhesions that was in the ascending colon. In such cases, the plane of dissection is always closer to your target organ. A little away from it will lead to an inadvertent injuries to the other vital structures. So you see now the use of gauze comes into the picture. You can one use it to dissect the tissues, and at the same time, if there's any bleeder, you can use it as a compression. So take your own time while dissecting. There's no hurry, and you should always use a sharp and blunt dissection. So you see, I'm taking a really long time to dissect here because one, we don't have planes over in acutely inflamed case. Number two, they're all adhesions present. So the use of gauze over here, see now I can see a plane because I used the gauze and then teased off the tissues. Now I can see the plane. And so this is why, use of your blunt and sharp dissection comes into the picture. You see, I'm using a little bit of sharp dissection followed by blunt teasing of the tissues using the gauze. So I'm almost reaching the base. I'm just confirming it. Uh, and there is a little bit of adhesive lysis which I have to do. So you see over here, I'm just taking down the meso appendix, and there's clearly a plane between the appendix and the meso appendix. And using the gauze to tease off the structures, and there's a bleeder. So this is what happens when you don't respect the tissues there. You should be gentle enough, and if it's bleeding, have compression. Never go to seal it first. Have because most of the bleeders will be settled with just compression alone. You see now that I've compressed it for 2 minutes and there is no spotter out there. Always, once there's a bleeder, check it, clean it up with saline to see if there's any further bleeding, and you can use your sealing device, either monopolar, bipolar, harmonic, whichever you have at your facility. And when you're nearing to the base of the appendix, you should be more judicious, more careful when using your energy device to make sure that you're cutting or you're using it on the mesoappendix and never on your cecum. So that's what when you're close to the base, you see the amount of energy usage has reduced. Now it is all into your gauze dissection. You see your gauze pretty much dissects very well, and you can clearly see the serous of the whole appendix coming there. And only when it's required you should use your energy device. Like again, hold it, lift it, and then you have to shoot. So I'm releasing some of those lateral additions to make the stump ready to use a endo loop. And once you're done, so now using a catgut endoloop. And the disadvantage of using a catgut is it can snap off your appendix in case of acutely inflamed appendices, and which happened in our case. There's always a risk of snapping when you use a catgut. I'm lucky enough to have a decent chunk of tissue to hold and apply another endoloop. You can always take a bite using 20 PDS or 20 Vicryl, provided you are good at endosuturing to close the appendicular stump. And finally, a bit of lavage and suction. Then, in such cases, better to put a drain. So, thanks a lot for spending your time in watching this. Please do like, share, and subscribe, and stay tuned for more educational content.